So students, after understanding the embryology and the osteology of the ear, let us come to the main topic, that is the anatomy of ear. So we'll first start with the anatomy of external ear, right? So now we know that the ear, it consists of three parts. What are the three parts? We have seen in the embryology also: external ear, the middle ear, and the inner ear, right? So we'll first talk about the external ear, and the external ear consists of your pinna and the EAC, external auditory canal, also known as external acoustic meatus, EAM, right? So let's first start with the pinna, right? So we have studied in the embryology that this pinna is formed from the first and second arches, 6 hillocks of his. All right, now what are the parts of pinna? So this part we have already studied. This is known as tragus. So anterior part known as tragus. Okay, and now this part is known as lobule. Okay, so remember, this pinna, whole pinna is made up of cartilage. Which cartilage? One single piece of yellow elastic cartilage, right? One single piece of yellow elastic cartilage. All right, what is the advantage of yellow elastic cartilage? Elastic cartilage, remember, it never ossifies. This question has also been asked, how many cartilages form the pinna? So it's a straightforward question, single piece, only one cartilage is there. All right, except at lobule. Remember, lobule does not have any cartilage, it has only fat. So this is the fat containing part of the pinna, only fat is there. So because only fat is there, the girls, they like to do a hole over here, that's known as ear piercing. And they like to wear jewelry on this lobule, right? So ear piercing is done at lobule. Why it is done at lobule? Because there is only fat. So when you do piercing through fat, it is relatively painless. The pain is there only at the skin, then there is fat, and then again there is skin, so there is little pain at the skin. If you go through cartilage, one thing, it's difficult to make a hole through cartilage. The other thing is that the cartilage on two sides is covered with perichondrium. So when it is covered with perichondrium, that is very painful. So remember, body piercing is always preferred at places where there is less cartilage, there is no cartilage, there is no bone, there is only fat. Okay, so lobule is the place where ear piercing is done. All right, so what are the other parts of the pinna? We can see that this is the helix. So surrounding the pinna, we have the helix. Okay, now opposing the helix, this is known as antihelix, right? And similarly, opposing the tragus, we have the antitragus. All right, okay. Now suppose I draw a line between the helix and the tragus. So you can see over here, this is our helix. So this is the curve of the helix, and if I draw a line between this helix and this tragus over here, now this line is known as incisura terminalis. What is the significance of this line, incisura terminalis? We know that the tragus is formed by first arch, and the remaining cartilage is formed by second arch. The remaining pinna is formed by second arch, okay, the hillocks of his. So therefore, this is the line of fusion of first arch and second arch. Okay, incisura terminalis is the line of fusion of first and second arch. And if I give an incision at this line, so what can happen? I can cut the skin, then this is the line of fusion. So I'll go between the cartilages. Okay, I'll go at the place of fusion of these cartilages, and I can reach the bone, right? So I can cut from skin to bone without cutting the cartilage. So that's the advantage of incisura terminalis. Let's look over here. You can see that you can cut and you can reach the bone over here without cutting the cartilage. So that's your incisura terminalis. Okay, and this approach to ear surgery, if you do an ear surgery like this, this approach is known as end-oral approach to ear surgery. Okay, so end-oral approach to ear surgery. Now, where do you give incision? You give incision at incisura terminalis, right? So you give incision over here. This incision is known as Lampert's incision, right? So this is known as Lampert's incision, in the end-oral incision, and then you cut over here, you open the pinna and you can operate inside in the ear. Right? Now, remember, there are 3 approaches to ear surgery. So, let's discuss all the 3 approaches. One I have told you is the end oral approach. You give incision at incisura terminalis. Now, the second approach is the post oral approach. So, you see over here, you give incision behind the pinna. Right? Now, what is the advantage of this incision? It is hidden behind the pinna, between the pinna and the hairs. So, cosmetically, this incision is very good because the scar will not be visible after surgery. So, this incision is very much preferred. This is the most preferred incision because the scar is not visible after surgery. Okay? And you know, this incision is known as Weil's incision. Okay? So, this is our post-oral approach. This is Weil's, or you can also call it as William Weil's incision, right? Post-oral approach, you cut the skin from here and then you expand and you can operate, you can go inside the ear, right? Now, the third approach is the endomeatal, or also known as transcanal or permeatal approach. So, permeatal, it gives you the hint, you give incision inside the EAC. Okay, so the incision is given inside the EAC. So, of course, scar will not be visible. Okay, so inside the EAC, you give the incision that is known as Rosen's incision. So, this incision that you are seeing, this is your Rosen's incision. All right. Now, the advantage is very good that the incision is inside the EAC. So, of course, it will not be visible to anyone. Okay, but the disadvantage is that the EAC is a very, very small tube. So, if you have to operate through the EAC, the number one, the canal should be broad enough. If we have a very, very narrow, tortuous canal in some people, then we cannot operate through the EAC. And then you cannot do all kind of surgeries through EAC. You can do only some surgeries through EAC. Right? So, that is known as endomeatal or transcanal or permeatal approach. Right? You give incision, you lift the flap. So, we see when I have lifted the flap of the EAC, so you can see over here, this is the bone, this is the incision, and now we can see over here, this is the malleus. Okay, we'll be talking about it. This is the malleus, this is the tympanic membrane that I have lifted up, and we can see over here the middle ear. So, we'll talk about all these structures later on, but yes, we can lift and we can operate inside the middle ear by this incision, by the Rosen's incision, the endomeatal or the transcanal or permeatal approach. All right. Now, let's come back to the pinna. So, we were discussing parts of the pinna. What all we have discussed? We have discussed the tragus, the helix, the antihelix, the antitragus. Now, this central part of the pinna over here, you see, this part is left. So, I am making a boundary of this part is left, this is known as concha. Okay, this depression, it is like a bowl. Alright, so this bowl shaped cavity in the center of the pinna, this is known as concha. Now, you see over here that the helix, you look at the helix, the anterior curve of the helix, it goes in the concha and it divides the concha into 2 parts. Alright. Now, which 2 parts? The superior part is known as cymba concha. The inferior part is known as cavum concha. Alright. So, superior part is known as cymba concha. The inferior part is known as cavum concha. Now, important for us is the cymba concha. So, why is it important? Because this is the surface landmark or anatomical landmark for mastoid antrum. Alright, this is the surface or the anatomical landmark for mastoid antrum. Now, we all know what is mastoid antrum. Mastoid antrum is the largest ear cell of mastoid. Remember, we discussed this in the embryology, largest ear cell of mastoid, and this is present at birth and it is of adult size at birth. Remember, mastoid process is not present at birth. Alright, so this mastoid antrum is present and is adult size at birth, and this is the surface or the anatomical landmark. Alright, now the next question over here is, suppose I want to do a surgery. We discussed that also in the embryology. So, suppose I want to do a surgery of the mastoid and I want to open this mastoid antrum. Alright, so what will I do? I'll give an incision behind the pinna like this. Post-oral incision. Why? I know that my mastoid process is also like this. Behind the pinna, behind this EAC, the mastoid process is like this. All right, and below this we have the antrum. So I'll give an incision behind the pinna like this. Okay, now what is this incision known as? This is the post-oral approach, and this is known as William Wild's incision. Now, any precaution that I have to take? You see, this is the mastoid process that I have drawn. You can see over here, this is the mastoid process. This is the tip of the mastoid process. All right, and I am giving this incision. But I told you in the embryology that this tip, it develops by 2 years of age. Okay, this tip develops by how much time? By 2 years of age. Right, now that means before 2 years this tip is not present. Okay, now this is the mastoid tip. Between the mastoid tip and the styloid process there is a foramen. Okay, which foramen? We will study about this foramen, that is the stylomastoid foramen. Now from this foramen comes out a nerve. Which nerve? We have the facial nerve. Okay, so this facial nerve comes out of the stylomastoid foramen and it then goes anteriorly into the parotid gland. All right, so if you give this Wild's incision in a child less than 2 years of age, what can happen? There is no mastoid tip. So this facial nerve is just below the skin and you can cut the facial nerve if you give the Wild's incision. So this incision, the Wild's incision, it is not given, it is contraindicated below 2 years of age because there is no mastoid tip. So if you give the Wild's incision, you will cut the facial nerve. All right, so to prevent injury you will not give incision below 2 years of age. So if you want to operate below 2 years, you can give a modified C-shaped incision like this. So this is the kind of incision that you can give. You go a lot behind the pinna like this, so you will not go like this below like you go in a Wild's incision. Okay, all right, so now let's come back to our first thing. We want to operate and open the mastoid antrum. So we give a Wild's incision like this. This is the adult patient, we give a Wild's incision, right? So we cut the skin and we reach the bone, the mastoid bone, and now we want to drill and reach the antrum. Okay, so what is my landmark? Where will I drill? Where will I drill to reach the antrum? Now some people will say Simba concha. Okay, so some people say Simba concha. Now remember, as soon as I cut the skin and I lift this pinna from the bone, my Simba concha is gone. This landmark, it's over here on the pinna. So when I lift the pinna from the bone, this landmark is gone. Remember, Simba concha, this is a surface landmark. So it is not useful to me during surgery. Are you getting it? This landmark is not useful for surgery. During surgery, I need a separate landmark. Okay, I need a bony landmark, or you can call it, I need a surgical landmark. Right? So Simba concha is an anatomical or surface landmark. As soon as you give incision and start doing the surgery, you lift the pinna, the landmark is lost. So now we need a surgical landmark. So we go back over here to the bone, the temporal bone. All right. So remember from the embryology, we have talked about this bone, the different parts over there. So let us look for a landmark where we can drill and reach the mastoid antrum. Okay. So I hope you remember the parts of the temporal bone. We have the squamous part. Okay, from the squamous part comes out the zygomatic process. This is the EAC. We have the mastoid part. You can see the styloid process over here, right? Between the styloid process and the mastoid process, we over here have a stylomastoid foramen. And I just told you what comes out of this foramen. From this foramen comes out a nerve. Which nerve? The facial nerve. It comes out like this. Okay, and it goes anteriorly. So if this tip, this mastoid tip is not present, this process is not present, and if you give an incision like this, you are likely to cut the facial nerve. Okay, now we were talking about the landmark. So we can see the EAC over here, right? Now what do you see? You see this zygomatic process. Okay, now this zygomatic process, you see, it goes backward as a slight bony elevation. All right, so I have marked that bony elevation, and this is above the EAC. above the meatus. So it is known as suprameatal crest. Right? So this bony elevation, this line is known as suprameatal crest. It is also known as inferior temporal line. Remember, there are two temporal lines on the skull. One is the inferior temporal line and the other is like this, that is your superior temporal line. In fact, the superior temporal line is mostly not on the temporal bone. It is rather on the parietal bone. So it is on the side, so it is known as temporal line. But the superior temporal line is usually on the parietal bone. It's not even on the temporal bone. The temporal bone, it has this suprameatal crest, which is also known as inferior temporal line, and that is your important MCQ, inferior temporal line. Okay, now that is our first landmark. All right, now we want to find a surgical landmark for mastoid antrum. So what we do is we take the EAC. Okay, so we take the posterior superior wall of EAC. So you see this wall, this is the posterior superior wall of EAC. We take this posterior superior wall, right? Number 3, we draw a tangent to the posterior wall of EAC. So posterior most point or the posterior wall of EAC, we draw a tangent. So you see this is the tangent to the posterior wall of EAC. Now what happens? In between these 3 landmarks, you can see that there is a triangle over here. All right, this triangle is known as McEwan's triangle or suprameatal triangle. All right, and this is the surgical landmark for mastoid antrum. The antrum is present 1.25 to 1.5 centimeter deep to this triangle. So this much you have to drill. You have to drill almost 1.5 centimeter. This much bone you have to drill so as to reach into the antrum. Okay, so this is the place for mastoid antrum. This is your bony landmark. On this you can see the pinna is there, and at very same place will come your Symba concha. So that's your surface landmark. But when you cut the pinna, you lift it up from the bone, that landmark is gone. Now we have the McEwan's triangle or suprameatal triangle. Right? Okay, so this is the surgical landmark for mastoid antrum, and the question that is asked in the exam is which of the following is not a boundary of McEwan's triangle. So as I told you, remember, we have inferior temporal line over here. We don't have superior temporal line. So usually they try to confuse you in the exam between superior temporal line and inferior temporal line. So remember, McEwan's triangle, we have the inferior temporal line as the boundary. Superior is not a boundary. Okay, and other 2 boundaries are posterior superior wall of EAC and tangent to posterior wall of EAC. Right? So this question is asked as an MCQ, and students who are preparing for their third prof part 1 exam in the ENT prof, this surgical landmark or the McEwan's triangle come as a short note. Alright, so if it comes as a short note, you have to draw this diagram, you have to draw the triangle, and you have to also write the significance that it's a surgical landmark. This is the place where we drill to reach the antrum. Alright. Okay, now let's go to the EAC. So that was our pinna. Let's come to the second part of the external ear, that is the EAC. So the EAC, we know it is approximately 24 millimeters in length. Alright, and out of this 24 millimeters, the lateral 1/3, this part is a cartilaginous part. So 8 millimeter is cartilaginous, and the inner 2/3, the 16 millimeter is bony. Okay, so outer 1/3 is cartilaginous and inner 2/3 is bony, right? The narrowest part of this EAC is known as isthmus. So as you can see, this is the narrowest part, and it lies 6 millimeter lateral to the tympanic membrane. So you can see over here, the EAC ends at tympanic membrane, all right, and this 6 millimeter lateral to tympanic membrane, we have isthmus. That's the narrowest part of the EAC, all right. Okay, now remember, you see over here, if you see this tympanic membrane is like this. It is at an angle of 55 degrees to the floor of EAC. So you see this tympanic membrane, it is forming an angle of 55 degrees to the floor of EAC. Now what happens because of this? You see, when I say floor, I actually mean the anterior inferior wall. Okay, I mean the anterior inferior wall of the EAC. So you can see the tympanic membrane is at an angle of 55 degrees to anterior inferior wall of EAC. That's a more specific answer. Now because of this, we see that this anterior inferior wall of EAC, that is the longest wall of EAC. You can see over here, this is the longest wall of EAC. And right opposite to anterior inferior, we have this wall. So what do we call this wall? We call it as the posterior superior wall. So this posterior superior wall, this you can see, this is the shortest wall of EAC. So this question is also asked, which is the longest wall of EAC? Answer is anterior inferior. Shortest wall of EAC, posterior superior. Right? Okay. Now next thing over here, that this outer 1/3, the cartilaginous part, this is the part that has the hairs, sweat glands, sebaceous glands, ceruminous glands. Okay, so hairs, sweat glands, sebaceous gland, ceruminous glands, all of them are present in which part? In the outer 1/3, the cartilaginous part. Okay, and all this is absent in the inner 2/3. Right? The inner 2/3 bony part does not have hair, sweat glands, sebaceous glands, ceruminous glands. These are present only in the outer 1/3 cartilaginous parts. Now something over here is important. What are ceruminous glands? What are these ceruminous glands? Okay, so the question is, what are these glands? Number 2, what they do? Right? So first question, what are ceruminous glands? Now remember, these ceruminous glands, they are modified sweat glands. All right. So somebody asks you, what are they? They are modified sweat glands. So let's talk about these sweat glands first, and then we'll come to the ceruminous glands. So you see, these sweat glands, they are of 2 types. Which 2 types? Number 1, they are eccrine sweat glands, or they are apocrine sweat glands. Eccrine sweat glands, you can also call them as typical sweat glands. Apocrine sweat glands are also known as atypical sweat glands. Okay, so typical, eccrine, or apocrine, atypical sweat glands. Now these eccrine sweat glands, what is their characteristics? Number 1, they are present all over the body. Okay, so almost everywhere we have the eccrine sweat glands. Now these apocrine sweat glands, they are present only at a few places. Few places like axilla and areola, the nipple areola area. Okay, then we have the pubic area. We have the circumanal area. So perianal or circumanal area. So only at a few places we have these apocrine or the atypical sweat glands. I call the mnemonic as AAA. Right? Axilla, areola, anal, so AAA. Right? Now the eccrine sweat glands, these glands, they secrete the secretions directly over the surface. Directly over skin surface. Right? Whereas these apocrine sweat glands, they secrete the secretions inside the hair follicles. So they secrete inside the hair follicles. Now these eccrine or the typical sweat glands, they are supplied by cholinergic nerve fibers. So eccrine, C for cholinergic. Okay, apocrine A, now these are supplied by adrenergic nerve fibers. Okay, so A, remember, AAA mnemonic, atypical, apocrine, atypical, adrenergic, axilla, areola, anal. So the mnemonic is AAA over here, right? So remember, they are supplied by adrenergic nerve fibers. Now, at a few places, these apocrine sweat glands are modified, right? These apocrine sweat glands, they are further modified at a few places, like in the EAC. So in the EAC, these sweat glands, these apocrine sweat glands, they are modified and they form ceruminous glands. All right. Similarly, the mammary glands, the mammary gland, the breasts. So what are breasts? The mammary glands, they are apocrine, modified apocrine sweat glands. Okay. Similarly, the ciliary glands in the eyelids. Okay. The ciliary glands in the eyelids, those are also modified apocrine sweat glands. So somebody asks you, what are ceruminous glands? All right. So you have to say the ceruminous glands are modified apocrine sweat gland. That is your complete answer. Okay, modified apocrine sweat glands. Okay, now the next question was, what do they do? What do they do? The ceruminous gland, what do they do? So simple, these are ceruminous gland. Now the ceruminous glands secrete cerumen. Okay, the ceruminous gland, they secrete cerumen. Now this cerumen, it mixes with the sweat. Okay, it mixes with the sebum. All right, it mixes with the hairs, with the dead cells. It mixes with the dust, and all of this together along with cerumen, now this is known as wax. So if somebody asks you wax, remember there's a difference between cerumen and wax. Many people, they say ceruminous glands secrete wax. That's a wrong statement. Ceruminous glands secrete cerumen. This cerumen mixes with everything and together it is known as wax. Okay, so somebody asks you the question, wax is secreted by. Question is, wax is secreted by ceruminous gland, sweat gland, sebaceous gland, all of the above. Then the answer is all of the above, because it's a mixture of all the secretions. Right? Now, what is the advantage of these ceruminous glands? What is the advantage of this wax? You see, the advantage of this wax is that it maintains the EAC at a pH of 3.9 to 4. So this is an acidic pH. And this acidic pH does not allow the growth of bacteria or fungi in the EAC. Keeps the EAC clean and sterile. Right? So that's the function of the wax. It keeps the pH at an acidic pH inside the EAC and does not allow the growth of bacteria or fungi inside your EAC. Right? Okay. Next question, nerve supply of ceruminous gland. The ceruminous glands, they are supplied by. Okay, so we all know ceruminous glands are modified apocrine sweat glands. So we know they're supplied by adrenergic nerve fibers. So now the examiner gives you a question that ceruminous glands, they are supplied by, and the choices are sympathetic, adrenergic, okay, sympathetic, cholinergic, parasympathetic, adrenergic, and parasympathetic cholinergic. Right? So we already know that these ceruminous glands, these are modified apocrine sweat glands, and apocrine sweat glands are supplied by adrenergic fibers. So cholinergic is out. Okay. Now, whether they are sympathetic or parasympathetic, now there are two ways to solve this question. The first way, we know that all the secretory glands in the body, they are what? They are under parasympathetic system. Okay. So all of them are under parasympathetic system except the sweat glands. Sweat glands are the only secretory glands which are under sympathetic system. Remember, sympathetic system is the system for fight or flight. Right? So, you are angry, you want to fight, you will sweat. You are scared, you want to run away, you will still sweat. So they are under sympathetic system. Right? Okay, another way to solve this question is that the parasympathetic system, it has only cholinergic nerve fibers. Alright, so that makes it easy. There is no adrenergic nerve fibers. Only the sympathetic system can have cholinergic nerve fibers or adrenergic nerve fibers. So when I say adrenergic nerve fibers, it automatically means that the system has to be sympathetic. It cannot be parasympathetic. Okay, because adrenergic nerve fibers, we have noradrenaline as the neurotransmitter. Okay, in cholinergic nerve fibers, we have acetylcholine as the neurotransmitter. Okay, and this noradrenaline, these adrenergic nerve fibers, these are seen only in the sympathetic system. So nerve supply of ceruminous glands is sympathetic adrenergic, right? Okay. Now that brings us to the tympanic membrane. So we have done the EAC, we have done the pinna. Okay, now that means we have done the external ear. Now we study the tympanic membrane. The tympanic membrane, it forms the lateral wall of middle ear. So ideally speaking, it is a part of middle ear, but it is easy to study and understand the tympanic membrane along with pinna and EAC. So we'll study in the external ear anatomy itself. All right. Now this tympanic membrane, what do we know about the tympanic membrane? We have studied embryology. We know something about tympanic membrane. This is formed from all three germ layers. Okay, it's formed from all three germ layers. So therefore, this tympanic membrane has three layers. It is a trimeric structure. Okay, it's a trimeric structure. So what are the three layers? So number one, we have the ectoderm. This ectoderm, it forms the outer epithelial layer. Okay, so that forms the outer epithelial layer. Then we have the mesoderm. This mesoderm, it forms the middle fibrous layer, right? It forms the middle fibrous layer. And number three, we have the inner endoderm. This endoderm, it forms the inner mucosal layer, right? So there are three layers of tympanic membrane: epithelial layer, fibrous layer, mucosal layer. All right, and remember these three layers, they are formed by three different germ layers. All right. Okay, now what is the dimensions of this tympanic membrane? So you see, if we say lengthwise, this tympanic membrane is approximately 9 to 10 millimeters. Okay, if we say widthwise, it is 8 to 9 millimeters, but these dimensions are not very important for you. What is important for you is the thickness. The thickness of this tympanic membrane, and it is 0.1 millimeter thick. Remember, in this 0.1 millimeter thickness, we have all the three germ layers, right? So thickness of tympanic membrane is 0.1 millimeter. Okay, now we can divide this tympanic membrane into two parts. Which two parts? We can divide into upper part and lower part. The upper part is known as pars flaccida, right? So upper part is known as pars flaccida, also known as shrapnel's membrane. The lower part is known as pars tensa, right? Pars flaccida and pars tensa. Now, why do we call it as flaccida or tensa? The name itself will suggest you. Flaccida means flaccid, tensa means tense. So that means pars flaccida is flaccid, the tensa is tense. Why? Question is why? Why is pars flaccida flaccid and tensa tense? Okay, so flaccida is flaccid because in it the fibrous layer is scanty and unorganized. Remember, it is not absent. Some book says it is absent. No, it is present, but it is very, very less in quantity, scanty, and whatever is there is unorganized. Okay, so scanty and unorganized. The pars tensa, on the other hand, has a very organized fibrous layer. Okay, so very organized fibrous layer. So therefore, this is tense. All right, this tense fibrous layer inside the pars tensa, it forms a ring. So you can see all around it there is a ring. This ring is known as fibrous annulus. All right, so the fibrous tissue condenses at this place at the periphery, and this is known as fibrous annulus, or you can even say annulus tympanicum, or you can say tympanic annulus. Okay, annulus tympanicum or tympanic annulus. Now, first thing, the name over here is fibrous, but this is not just fibrous. This annulus is fibrocartilaginous. So there is some cartilage component present over here also. Okay, so this fibrous annulus is fibrocartilaginous. And what is the function of this fibrous annulus? The function of this fibrous annulus is it attaches the tympanic membrane to the EAC. Right? This gives an attachment of tympanic membrane to EAC, the fibrous annulus. All right. Now let's look over here. Before we go forward, let's look over here. Now let's look in this diagram. You see, this is the EAC that I'm not drawing. Now this is the medial end of EAC. On this medial end, we have the attachment of tympanic membrane. Right? So I'm drawing the EAC. We can see the medial end of tympanic membrane. Okay, and then from here starts your middle ear. Right? So we'll discuss the middle ear later on, but that's your middle ear, and we have the tympanic membrane over here. Now, at this medial end of the EAC, this is the bony EAC, remember? Okay, the medial 2/3. This bony EAC forms a rim for the attachment of tympanic membrane. Okay, so we have that place for attachment of tympanic membrane over here, and this place we have formation of a rim. Right? Like this, the bony EAC, it forms a rim. This rim over here, this is known as bony annulus. Okay, so this rim all around is known as bony annulus. Now what is the advantage of bony annulus? The advantage of bony annulus is that on this bony annulus attaches over here the fibrous annulus. Okay, so on this attaches the fibrous annulus, and this fibrous annulus is the periphery of pars tensa. So you see, it will give attachment of tympanic membrane to the EAC. So that's the fibrous annulus, and it goes and attaches to the bony annulus of the EAC. Okay, so that was one view. Let's look at this from another view. So what I'm going to do is I'm going to make the EAC. So this is our EAC. Right, and in this over here we have the medial most end where the tympanic membrane is attached. Right, so that is the EAC wall, and we have the tympanic membrane attachment. Now for attachment of tympanic membrane, the bony EAC, it forms a rim. So all around on the medial aspect, it forms a rim. That rim is known as bony annulus. Okay, on this is attached the fibrous annulus, and then the fibrous annulus attaches the tympanic membrane to the EAC. Now you see, this bony rim, the bony annulus, is deficit at a point superiorly. It's absent, it is missing superiorly. That place is known as notch of Rivinus. Okay, so what is notch of Rivinus? Notch of Rivinus is a deficiency in the bony annulus. The bony annulus is deficit, it's missing at a point superiorly, so that's known as notch of Rivinus. And what covers the notch of Rivinus? This notch of Rivinus, of course, is covered by pars flaccida. Remember, in flaccida, the fibrous layer is scanty, unorganized. So therefore, in pars flaccida, we don't have the fibrous annulus. Right, we don't have the annulus tympanicum. So in this part, the pars flaccida itself covers the notch of Rivinus. We don't have a fibrous annulus, we don't even have a bony annulus at this place. Okay, so we have pars flaccida that covers the notch of Rivinus. All right, so let's go back over here to this diagram of the tympanic membrane. So we see in this part over here, we have the bony annulus over here. So we can see the fibrous annulus. So below this we have the bony annulus over here. Okay, but this part we don't have the bony annulus. Okay, so this part you can see it is covered by the pars flaccida, the Schweppes membrane. All right. Now, what else can we see over here? What all structures other than this that we have discussed we can see on the tympanic membrane? We can see over here the handle of malleus. So we know the malleus is the ear ossicle, and this is the handle of malleus, also known as manubrium. This we can also call as manubrium, and this is the handle of malleus we can see on tympanic membrane. Now the tip of this handle of malleus. You see, this tip of this handle of malleus, that's known as umbo. Right? The tip is known as umbo. What is the significance of umbo? Umbo is the most visible landmark of tympanic membrane. This is right in the center. Most visible landmark of tympanic membrane. Okay? So that is known as umbo. When you look at tympanic membrane, this is the first thing that you will notice. And it is the most important, or you can say this is the anatomical landmark of tympanic membrane. Okay, it's a very important anatomical landmark. Why it's an anatomical landmark? We can study the anatomy with this landmark. How we can study the anatomy? What you do is you draw the first line going through handle of malleus. Okay, so I have drawn one line going through handle of malleus. Of course, it will pass through umbo also. Okay, now you draw the second line perpendicular to the first line. But the second line also has to pass through umbo. So you see, the second line is perpendicular to first line, but is also passing through umbo, and then you end up dividing the tympanic membrane into 4 quadrants. Which 4 quadrants? Anterior superior, anterior inferior, posterior inferior, and posterior superior. So with the help of umbo, we can divide the tympanic membrane into 4 quadrants, so we can study each quadrant separately. Right? So that is why umbo is the anatomical landmark for tympanic membrane. You see, whenever we choose landmarks, we choose bony landmark. Why do we choose bony landmark? Because they are fixed. They don't move from their place. If some disease is there, they will remain fixed so that we are still able to orient with the anatomy around them. But with umbo, we have a problem. What's the problem we have in the umbo? Okay, let's say this, my hand over here, this is the malleus. Okay, so malleus has different parts. What are the different parts? It has a big head. So you see this over here, the fist is a big head, right? Then there is a very small neck. Okay, we have a very small neck. Then there is handle of malleus. What do we call it? We can also call it as manubrium. And then there is tip of malleus. This tip is known as umbo, right? Head, neck, handle, and the tip, the umbo. Now you see the malleus moves like this. Okay, so which is the most mobile part of malleus? Umbo. Umbo is the most mobile part of malleus. Malleus is a mobile bone. So we chose umbo as a landmark because it's a bony landmark. But despite being a bony landmark, it is mobile, it moves. So if there is a disease, it will move out or it will move in. Right? So therefore, we cannot, correlate with the anatomy around it. It's not a reliable landmark. Okay? Umbo is not a reliable landmark. It is the anatomical landmark. It is the most visible landmark, but it is not a reliable landmark. Okay? Now, before we go ahead, let's see over here. You can see some light shining over here. Okay? So what is this shining light? This is known as cone of light. Okay, so this shining light is known as cone of light, right? And this cone of light is present in which quadrant? It is present in anterior inferior quadrant, right? So this question is asked, cone of light is present in anterior inferior quadrant of tympanic membrane. Okay, and I was talking about the reliable landmark. Umbo is not a reliable landmark. So somebody asks you, which is the most reliable landmark of tympanic membrane? So you see, you have to choose a bony landmark. Okay, but you have to choose a bony landmark which does not move. So we have a process over here that's known as lateral process of malleus. Now let's look at my hand model once again. So as I told you, this over here we have the malleus, the head, the neck, the handle, and then the tip. Now at the neck we have a short process that's known as lateral process of malleus. Okay, now the malleus is moving like this. Okay, in and out it is moving like this. So you see the head is moving, the handle is moving, the tip of course is moving the maximum, but this neck is stable. Okay, and what's there on the neck? On the neck we have the lateral process of malleus. Alright, so this lateral process of malleus, this is the most reliable landmark of tympanic membrane. Okay, that's alright. But is it having any use? is this lateral process useful to us? Does it help us identify something? Yes, we have already studied. You see over here, above this lateral process, we have the pars flaccida, and below this lateral process, we have the pars tensa. Okay, so it helps us divide the tympanic membrane into two parts, pars flaccida and pars tensa. Right, so that's the significance of lateral process of Malleus. Most reliable landmark of tympanic membrane, helps us divide tympanic membrane into pars flaccida and pars tensa. All right, okay. Now, before we go forward, this is a question that I want to ask. What is this cone of light? We know some light is present over here. Why this light is present only in the anterior inferior quadrant? Okay, so as we just discussed, we have this cone of light in the anterior inferior quadrant. So what is this cone of light, and why is this cone of light present only in the anterior inferior quadrant? Why don't we have cone of light in other quadrants? Okay, to understand this, let's go a little back. So to understand this cone of light, let's come back to this diagram. Okay, so as I told you over here that the EAC, it forms an angle of 55 degrees with the tympanic membrane. So tympanic membrane is at an angle of 55 degrees to which wall of EAC? Floor of EAC, or we called it as the anterior inferior wall of EAC. Right? Okay, so this part we have already discussed. Now if you see, the tympanic membrane is not flat. If you look in this photograph, it is not flat like this. Rather, the tympanic membrane has been pulled in like this because of attachment of the handle of Malleus like this. So look over here, we have the handle of Malleus attached to the tympanic membrane, and from the center, the handle of Malleus is pulling the tympanic membrane inside. All right, okay, now suppose I want to see the tympanic membrane, what will I do? I will shine the light on the tympanic membrane. Okay, so you see my light rays, they come like this. Okay, so now when the light rays, they come like this from outside to inside. Now because of this pull of the tympanic membrane by the handle of Malleus, this anterior inferior part of the tympanic membrane, it becomes perpendicular to the light rays. So earlier you see the tympanic membrane was like this at 55 degrees to the floor of EAC, but the pull brings it to 90 degrees at this particular place. Which place? Anterior inferior quadrant. And then this epithelium, it reflects back the light. The 90 degree reflects back the light. Okay, and it shines, which is known as cone of light. So cone of light is seen in which quadrant? Anterior inferior quadrant. Okay, why it is seen? It is seen because of the reflection of light. So why it is reflecting light? Which structure is responsible for this cone of light? Answer is handle of Malleus. Okay, this handle of Malleus pulls the tympanic membrane inside and brings the tympanic membrane to 90 degrees so that it is able to reflect back the light rays. Okay, so this question is asked, cone of light is seen in, answer is anterior inferior quadrant of tympanic membrane of pars tensa. Okay, cone of light is seen in. Cone of light is seen due to. So if the question is due to, then it is due to the handle of Malleus. Alright, handle of Malleus brings the tympanic membrane to such a particular angle that it reflects back the light. Okay, so these are the two questions. Now, this knowledge also brings us to some more questions. Let's look at them. All right, so there is a foreign body in the EAC. You can see over here, there is a foreign body. Now, how will you remove this foreign body? The child has come, he has while playing put some foreign body like a stone in the ear. Okay, so how will you remove the foreign body? So very simple, you can use a probe. Okay, you can pass this probe behind the foreign body and bring the foreign body out. Okay, so this probe is known as Jobson-Horn probe. This probe is known as Jobson-Horn probe. It has a ring current. This ring current is engaged behind the foreign body and the foreign body is brought out. So probing is one way of removing the foreign body. What else can you do? You can use a microforceps. So this over here is the microforceps that you take and you hold the foreign body and bring it out. Now remember, it's very difficult to hold a spherical foreign body. But if the foreign body has a sharp edge, like a paper, it's very easy to remove with the microforceps. So you can just hold the paper and bring it out. Alright, so microforceps can be used. What else can we do? We can do syringing. Now to do syringing, we use a Simpson's oral syringe. Alright, so this is your Simpson's oral syringe. This is a 50 ml syringe. Okay, what is this? This is a 50 ml syringe. And what you do in this, you fill this 50 ml syringe with water at core body temperature. Okay, so core body temperature means 37 degrees Celsius. Right? You use it at core body temperature at 37 degrees Celsius. Why do you do syringing at 37 degrees Celsius? Because if you use cold water or if you use hot water, that will stimulate the inner ear. Okay, this will stimulate the inner ear and the patient will have vertigo. Okay, this is known as caloric stimulation. Right? This is known as caloric stimulation of inner ear. So if you use very cold water or you use a hot water, that will stimulate. So patient will have vertigo. You don't want the patient to have that dizziness, vertigo. So you will use at core body temperature. Okay, so you can wash the ear, wash the EAC with this syringing. Right? Now, so this is what we do. We do syringing. Okay, is there any particular way of doing syringing? Is there any particular direction? You can see my hands over here. Am I directing in some particular way? Yes. Okay, you see, suppose the foreign body is over here in the EAC, right? And if I do syringing like this, so you can see if I am doing syringing like this, the water will of course take the foreign body inside. It will not bring it back. So there has to be some particular way of doing the syringing. Okay, so that particular way is we do syringing in the posterior superior direction. So which direction? Posterior superior direction. Why posterior superior direction? So as I told you that the anterior inferior angle is 55 degrees. The posterior superior angle therefore becomes a obtuse angle, big angle. Okay, so the water, it goes along the EAC. As you can see over here, it goes along the EAC, takes a turn at this big posterior superior angle. Okay, because it's a big angle, it will not damage the tympanic membrane, and then it comes out and it brings the foreign body out. Okay, so this question is asked in the exam. What is the direction of syringing? So direction of syringing is posterior superior direction. All right. This question is also asked in the exam. Cold water is not used for ear cleaning because it will make the wax hard. No. Damage to tympanic membrane, that's dependent upon the angle you are using. Caloric stimulation caused by cold water. Yes, because the cold water will stimulate the inner ear and patient will have vertigo, dizziness. Okay, so answer is caloric stimulation by cold water. So that is why we don't use cold water, or for the same reason hot water. Okay, now we've talked about syringing. Question that I would like to say before I go ahead: what are the contraindications for syringing? When will you not do syringing? Okay, so number one, we have, suppose there is a impacted foreign body. Okay, so you see this is an example of impacted foreign body. Now the foreign body has completely blocked the EAC. So if you do syringing, the water will not go behind this foreign body. So you cannot remove it by syringing. For the same reason, you cannot remove it by probing also. Probing also you cannot do. Okay, what about, holding it with the forceps? So this is a spherical foreign body. You will not be able to hold it with forceps also. Okay, so even micro forceps cannot be used in this foreign body. Okay, now what are the other contraindications for syringing? There is a tympanic membrane perforation. Why? Because the water will not come back. Number 3, there is acute infection. Okay, there is acute infection of external ear or middle ear. It will be very painful. So then you cannot do syringing in these cases. Right? Okay, how will you remove this impacted foreign body? This can be removed with the help of microsuction. So suction under microscopic view. So now what you do, you use a negative suction. Okay, this negative suction pulls the foreign body out. Now you are using a microscope. So what is the advantage of using this microscope? The advantage is that this will magnify the EAC. The chances of damage to the EAC or the tympanic membrane goes minimum. Okay, so microsuction, remember, this is the best way to remove a foreign body. Best way. Why? Because you are using a magnified view by using a microscope, you are using a negative suction, so you are not putting something behind the foreign body, you are just pulling it out by the negative suction. So this has minimum chances of damage to any structure. This is the best way, the most comfortable way for the patient to remove a foreign body, to clean the EAC. Right? Okay. Now, another question, let's say we have a live insect. You can see over here, there is a cockroach. Okay, so there's a live insect in the EAC. Now, how will you remove this insect from the EAC? Remember, why the insect goes inside the EAC? It goes inside the EAC because EAC is a dark place. So normally the insects, they live in the crevices, burrows. Those are dark holes. Okay, now suppose there is a rainy season and all these burrows, these crevices, they are filled with water. So they are looking for a place that is dry, that's a little hot, warm, okay, and that is dark. And the EAC, you see, the EAC is dry, it is dark, it is warm, so the insect goes inside the EAC to sleep. Especially in the night time, if you are sleeping on the floor bed and the insect goes inside. So as soon as it goes inside, you will have a lot of irritation, you will wake up. Now you want to remove the insect. So what can you do? You see, if you shine the light, the insect will run away from the light. It will go away, it will go back. Okay, so you see, you cannot shine the light. That means microsuction is out. You cannot use microscope, you cannot do suction, microsuction is out. Okay, for the same reason, the probing is out. You cannot do probing, that needs light. For the same reason, you cannot even use microforceps. Okay, can you do syringing? No, you should not do syringing also. Why? Because if you do syringing, what will happen? You will irritate the insect with water. And the insect, because of the flow of the water, it may try to retain itself, so it may take a bite of the tissue. Okay, so that will damage the EAC. Patient will have a bite by the insect inside the EAC. You don't want that. Till now, the insect has not bitten. It has not gone inside to bite. It has gone inside to sleep. Alright, so what will you do now? How will you remove this insect? The best way to remove the insect is by putting a few drops of oil, lukewarm oil, any non-irritant domestic oil, you know, you can use vegetable oil, coconut oil, so mustard oil, any oil that is available in the home, non-irritant oil, right? You can put a few drops of oil in the EAC. Now, what is the advantage of this oil? You see, when you put oil, now the EAC is flooded with oil, insect cannot breathe inside oil. So insect will itself come out on its own without you doing anything else. Just put a few drops of oil and you will see the insect comes out on its own. So this is how we remove a live insect from the EAC. Alright, so before we go ahead, let's watch a small video. So this is a case of a foreign body in the ear of a patient. An insect has gone inside and they're trying to remove the insect by putting some drops. So this is not my video, okay, but they're putting some drops. I hope those are oil drops. I don't know which drops they're putting. But you see, they're trying to shine some light, not inside the ear, but around the ear, so that, you know, they can record this video for you. but because of the light, the insect is not coming out readily. So you have to wait for some time. All right, you see the insect coming out. Okay, so insect comes out on its own after you put some oil drops. Right? So the best way to remove a live insect from the ear is by putting some lukewarm oil. So let us now discuss the nerve supply of the external ear. So we know external ear has two parts, pinna and EAC. Okay, so let us first discuss the nerve supply of pinna. So we know that the pinna is formed by two arches, the first arch and the second arch. So the anterior part of the pinna is formed by which arch? The first arch. So you can see over here that the anterior part of the pinna is supplied by auriculotemporal nerve, branch of V3. V3 stands for mandibular nerve. Okay, so mandibular nerve is third part of fifth cranial nerve, that is your trigeminal nerve. Okay, remember trigeminal nerve has three branches: ophthalmic branch, maxillary branch and mandibular nerve branch. Okay, so V1, V2, V3, and V3 is the mandibular nerve, the nerve of first arch, and that supplies the anterior part of the pinna, auriculotemporal branch of mandibular nerve. Okay, now you see over here the green color concha. This is supplied by seventh nerve. Remember, the second arch nerve is the seventh nerve. So the concha is supplied by seventh nerve along with fibers of 10th nerve. But if you notice the majority of the pinna, this is supplied by a nerve coming from behind. Okay, so like this it comes from behind, and this nerve, unlike the mandibular nerve or the seventh nerve or the 10th nerve, this is not a cranial nerve. Okay, remember, these are cranial nerves, but this nerve is a spinal nerve. Okay, it is known as greater auricular nerve. It is a spinal nerve. It has the supply of C2 and C3. This is your greater auricular nerve. It supplies the majority of the pinna. All right. Now, this pinna, it has two surfaces. What we just saw was the lateral surface. Okay. We also have a small medial surface. So, if I rotate the pinna, we can now see the medial surface. Now, on the medial surface, once again, you see that the majority part over here is supplied by the greater auricular nerve, C2, C3. So, the nerve is coming from behind. It first supplies the medial aspect of pinna, then only it rotates and goes to the lateral aspect of pinna. Okay. Small part superiorly is supplied by lesser occipital nerve. Okay. Right. So, this is the nerve supply of the pinna, both on lateral and medial aspect. Now, before I go ahead, let's discuss about ear piercing once again. So, remember the ear piercing, where the ear piercing is done? It is done at the lobule. Why? Because there is no cartilage, there is only fat. So, the advantage is no pain or less pain during piercing. What is the disadvantage? No cartilage means not much support. Support is also very less. So, if you wear a very heavy jewelry, okay, or if you wear a jewelry which is hanging over here, right? So, heavy jewelry will cut through this pinna, through this lobule slowly. Now, if you wear a long hanging jewelry, it can get stuck in some clothes, and when you pull the ear like this, when you rotate your head, the pinna is pulled, the lobule is pulled, and it can cut through. So, we can have a condition over here where the lobule is cut through by this jewelry. So, this condition is known as split lobule. Okay, that's known as split lobule. Now, first thing, what will you do for split lobule? So, many students, they will just tell me, sir, we'll suture it, we'll repair it. Yes, we'll repair it. Of course, we have to repair it. But this repair is different from other suturing. Why? Number one, no patient would like a scar over here where she has to wear a jewelry on the lobule. Okay, so you have to repair this in a way that there is no scar. It should be a scarless repair. All right. Number two, she wants to wear the jewelry once again. So the repair should have a lot of strength. All right. You have to give it adequate strength so that if she wants to wear the jewelry again, she can wear it again without the risk of getting split again. Okay, so you know the fibrous tissue, if we just do a straight repair, there is a straight fibrous tissue after the repair, and the jewelry can easily cut through the fibrous tissue, much more easier than earlier, okay, when only fat was there. So this repair is therefore known as lobuloplasty. So what is lobuloplasty? That's repair of the split lobule. First thing, which nerve block do we use for lobuloplasty? So that's the easy answer now. The nerve block used for lobuloplasty is greater auricular nerve, C2, C3. Why? Because it supplies both the lateral aspect as well as the medial aspect. Okay, so both the aspects are supplied by the greater auricular nerve. So that's the nerve block you use for lobuloplasty. Okay, now you see, why do we do piercing at the lobule? I just told you, because there is, you know, only fat, there is no cartilage. You see, the piercing started thousands of years ago. At that time, there was no local anesthesia. Okay, so there was no antibiotics also. If the perichondrium gets infected, the patient cartilage will undergo necrosis. So the whole pinna will be destroyed. So there were no antibiotics, there were no anesthetists. So there was no anesthesia, there was no local anesthesia. So therefore the piercing was preferred at the least dangerous place, least painful place. But now we have local anesthesia. We know that the greater auricular nerve is coming from here, and if I give a small anesthesia over here, then you know I can do multiple piercing at the same sitting, and I can even cover it with antibiotics, so the chances of infection will also be less. I have all the sterile instruments, so I can easily do multiple piercing. So now instead of going single jewelry at the lobule, big jewelry, now the people prefer multiple small jewelries. Okay, so people go for multiple piercing, designer piercing. You can design your piercing as per the jewelry you wish to want. Okay, you can do as much piercing as you want. All right, and remember, each piercing has a particular name, right? So on the tragus, we have a tragus piercing, then we have a conchal piercing, we have a orbital, we have a, this is the standard lobe piercing. Okay, you can pierce at the antitragus. Anyways, so these names are not for you, just wanted to show you that we can do different kinds of piercing, right? All this is possible now because we have good anesthesia. You can give local anesthesia, you can block the nerve, and you can give the different piercing, right? Okay, another question which was asked in the exam, you can see in both the patients, these are the patients of leprosy, and you can see the nerve is thickened. So this is the thickened greater auricular nerve in leprosy. So this question has been asked, identify the thickened nerve in a patient of leprosy. So what they are basically asking you, they are asking you the surface marking of the greater auricular nerve. So let's see this greater auricular nerve. It starts from here, from the posterior border of SCM. So this is the sternocleidomastoid muscle. From the posterior border of SCM, the greater auricular nerve comes out and then it travels up. So we can say that you can see over here, this is the lesser occipital nerve, that's quite posterior, and this over here is the greater auricular nerve. It is traveling up to the neck like this. Some part also goes anteriorly over here. Okay, over the parotid area you can see. So this is the greater auricular nerve, this is the nerve, this is the surface marking of the greater auricular nerve, right? Okay, another question, rhytidectomy. What is rhytidectomy? Now before that, what are rhytids? Rhytids are your facial wrinkles. So as you can see over here, this lax skin, these are known as rhytids, wrinkles. Now what do we do for rhytids these days? Suppose a patient wants to get rid of these facial wrinkles, these rhytids. So what do we do these days? These days, you know, we do a lot of Botox injection. So what will this Botox injection do? It will paralyze the neuromuscular junction, and the muscle is paralyzed and the wrinkle disappears, right? So we do a lot of Botox injection to get rid of these rhytids. Now what is the advantage of Botox injection? There is no surgery required, just inject it, done. What is the disadvantage? The flip side is that this Botox, it works for only few months, 3 to 6 months. So after that, the effect of Botox will go away. So you have to get this repeated. All right. So many people, they like, especially the actors and the actresses, they don't want their age to show on their face. So they get this Botox injection done regularly. But you know, we have this lady over here, and the skin has actually become very lax and it is hanging. You see, this skin is hanging. It's a loose skin. It is now hanging. So the Botox will not work over here. Now we have to do a surgery that is known as rhytidectomy. It will remove all the extra lax skin over here from the face. So that is known as rhytidectomy. It's a surgical removal of rhytids, facial wrinkles. And how do we do this surgery? How do we do the rhytidectomy? We give incision around the pinna. Okay, so we give incision around the pinna. We lift the skin of the face. All right, and we cut the extra skin. We pull back the skin and we repair it. We suture it again. So because we lift the skin of the face, this is also known as face lift operation. Okay, this is known as facelift operation. So anyways, improving the face. So again, it is known as facelift. Okay, so you can see this is before and after, and the lady looks much younger, right? So that's your facelift surgery. All right, you can see over here that it's a drastic change. So yeah, all these facial wrinkles are visible, and this is after the surgery, right? How can you say that the facelift, the rhytidectomy has been done? Look over here, and you see that they have all moved back, right? So the skin has been stretched, right? So this is your rhytidectomy, the facelift operation. Okay, now remember over here, what incision do you give in rhytidectomy? This is the incision. This is the rhytidectomy incision. You give around the pinna. Okay, so question asks, what is the most common nerve? Most common nerve injured during rhytidectomy. Okay, so you see the greater auricular nerve comes like this. So most common nerve injured during rhytidectomy is greater auricular nerve. Okay, now this is a sensory nerve. Somebody asks you which is the most common motor nerve. Motor nerve injured during rhytidectomy. So most common motor nerve is zygomatic branch of facial nerve. So zygomatic branch of facial nerve, that is the most common motor nerve, but overall most common nerve is the greater auricular nerve, right? Okay, now the next question we have over here is the modified Blair incision for peritodectomy. So you can see this is the modified Blair incision. Now once again we have the greater auricular nerve coming over here. So we see over here it barely survives this modified Blair incision. Okay, so over here in the rhytidectomy incision, this was, there are a lot of chances for this being cut, but in the modified Blair incision we can see that it survives the incision, barely survives, but sometimes the surgeon can cut this nerve also. Okay, so the question asked from this diagram over here is that in a patient of peritodectomy, what will happen if you cut the greater auricular nerve? So if you cut the greater auricular nerve, the patient will have anesthesia in this area. Which area? In the pinna, okay, lobule of pinna, and in this area. What is this area? This is the shaving area. Okay, this area over here, this is the shaving area of face. So patient will have anesthesia during shaving. All right, he will not feel the skin. So if the anesthesia is there, that means the greater auricular nerve has been cut during peritodectomy. Remember, during peritodectomy we can also see a damage to the auriculotemporal nerve. Okay, so auriculotemporal nerve is over here, it supplies this area. So that is not the shaving area. You can see over here the hairs are still there. This is not the shaving area. But if the auriculotemporal nerve is damaged, we have another syndrome, and that is known as Fraze syndrome. Okay, that we will study later. So but remember, in auriculotemporal nerve injury we have the Fraze syndrome that is seen after percutaneotomy. And if the greater auricular nerve is injured, then we have over here anesthesia on the pinna, on the lobule, and in the shaving area. Right? Okay. Now let's come to this question. Question asked, following percutaneotomy, numbness on face while shaving is due to injury of which? So we have just discussed, this question was asked in the May 2019 AIIMS exam. The answer is greater auricular nerve. Right? Okay. So this will cause the numbness to shaving area. The auriculotemporal nerve, it will cause a syndrome known as Fraze syndrome that we will discuss later. Okay. So now we come to the nerve supply of EAC, external aortic canal. So you can see this is the EAC. So around the tympanic membrane, we have the EAC, and we have divided this EAC into 4 quadrants. Okay. So we can see that EAC has been divided into 4 quadrants. Number 1, we can see the anterior superior quadrant. Now in the anterior superior quadrant, we have once again the supply of auriculotemporal nerve. So this we have already discussed, auriculotemporal nerve, that's a branch of the mandibular nerve. So it supplies the anterior part of the pinna. It also goes and supplies the anterior superior part of the EAC. Then anterior inferior part, you see, this is supplied by Arnold's nerve. Okay. So that's a branch of vagus, 10th cranial nerve. Okay. So Arnold's nerve is sometimes also known as auricular branch. So auricular means ear branch of vagus, auricular branch of vagus, that's the Arnold's nerve. Right? It supplies the anterior inferior part of EAC. Now you see, suppose somebody asks you cuff reflex. Okay. Somebody asks you cuff reflex, and cuff reflex is due to, the cuff reflex, remember, is due to the internal laryngeal nerve in larynx. And this internal laryngeal nerve, that is a branch of superior laryngeal nerve, which is a branch of vagus 10th cranial nerve. Okay. So cuff reflex is in larynx. It is due to the internal laryngeal nerve. We will study more about it when we discuss the topic of larynx. Now, however, cuff reflex during ear syringing. So if you do ear syringing, or if you do probing in the ear, and sometimes you stimulate this Arnold's nerve, it can also cause cuff reflex. Okay. So cuff reflex during ear syringing is due to the stimulation of Arnold's nerve. Right. Okay. Posterior inferior supply is by C3, and that's not very significant. So let's go to the supply of the posterior superior part of EAC. Now we come to the posterior superior supply. So posterior superior part of the EAC is supplied by the facial nerve. Now this is a very important nerve supply. Why? Because in this part, this is the part which is supplied by sensory component of the facial nerve. Okay. And if this sensory supply by the facial nerve is absent, it is known as Hitzelberger sign. Okay. This Hitzelberger sign is seen in vestibular schwannoma. Right. So posterior superior part of EAC supplied by facial nerve, and if this sensory supply by facial nerve is absent in the posterior superior part of EAC, that is known as Hitzelberger sign, and this sign is seen in vestibular schwannoma. So that is the nerve supply of the EAC. Alright. Now we come to the nerve supply of tympanic membrane. To study the nerve supply of tympanic membrane, what we can do is, we can divide the tympanic membrane into 2 halves. So like this, I can draw a line and I can divide the tympanic membrane into 2 halves, anterior half and posterior half. Okay. Anterior half is supplied by auriculotemporal nerve, which we just discussed is a branch of mandibular nerve. Posterior half is supplied by Arnold's nerve, and that is a branch of vagus 10th cranial nerve. Right. Okay. Now you see, the tympanic membrane has 2 surfaces. Just like my hand, it has 2 surfaces. There is a lateral surface that's facing the EAC. This is the medial surface, and it is facing the middle ear. So I have just told you is the nerve supply of lateral aspect of tympanic membrane. Okay. Anterior half auriculotemporal nerve, posterior half Arnold's nerve. That's the lateral surface of tympanic membrane. Now what about the medial surface of tympanic membrane? Okay. So before we go there, let's look at this question. Cuff reflex on scratching the floor of EAC is due to which nerve? Okay, so we know that is answer is Arnold's nerve, also known as auricular branch of vagus. Okay, and this question was asked in the NEET PG 2020 exam. Right? Okay, right. Now let's look at this. This is the medial surface of tympanic membrane. Okay, so this photograph has been taken from inside the middle ear. You can see the medial surface of the tympanic membrane, and this is supplied by Jacobson's nerve. Jacobson's nerve is a branch of 9th cranial nerve, glossopharyngeal nerve. This you can see is a beautiful photograph of the middle ear taken from inside the middle ear. So how they have taken the photograph? They've passed a camera through a fiber optic camera. They have passed through the eustachian tube and they have reached the middle ear, and then the light has been shined in the EAC. So you can see the shining light illuminating the tympanic membrane and the middle ear, and then this camera has clicked the photograph. Okay, so that is the medial aspect of the tympanic membrane supplied by Jacobson's nerve. Now you see, in fact, the whole middle ear is supplied by the Jacobson's nerve. Okay, all the walls of the middle ear are supplied by Jacobson's nerve. So Jacobson's nerve is the sensory supply of middle ear. So this question is also asked, the sensory nerve supply of middle ear, answer is Jacobson's nerve. So not just the medial aspect of tympanic membrane, it supplies all the walls of the middle ear. Right? Okay, now let's look over here. This tympanic membrane we just discussed. The lateral aspect, we have the anterior half auriculotemporal nerve, posterior half we have the Arnold's nerve, and on the medial aspect we have the Jacobson's nerve, branch of glossopharyngeal nerve. Okay, so that is the nerve supply of the tympanic membrane. So with that we finish the anatomy of the external ear as well as the tympanic membrane.